I'm the chairman of the Diabetes Task Force at Emory University, and we have 56,000 patients with diabetes. And the community hospital has 18,000 patients. So I kind of oversee the care of about 80,000 patients, and we have about 3,000 patients with type 1 diabetes. So I get to see type 1 almost every day in my practice. And it's going to be a weak contrast of trying to initiate care and what I would propose to you that we have gone beyond insulin therapy. So with that started, I will try to tell you what are our unmet needs on patients with type 1 diabetes. What are the limitations of insulin despite having pumps, sensors, analogs? We still have many, many patients who do not achieve goals. And talk about what else people are thinking. What else can I give my patient with type 1 diabetes to improve control beyond insulin therapy, especially the new agents that now has been coming on board. So the other thing is that this lecture is very appropriate in the way that not everybody in this room is an endocrinologist. And what you see in here is that who sees patients, at least in the United States, where patients with type 1 diabetes, and most of the patients are seen, or about half are seen by primary care, and half is seen by endocrinologists. So if we have 1.5 million people in the United States with diabetes, with type 1 diabetes, and we have about 8,000 endocrinologists board certified, and 10% are pediatrics. So we have about 1,000 for 1.5 million people. So it cannot be just managed by an endocrinologist, it has to be by primary care, and our job as specialists is to educate the community to improve care. So the other thing is how people is managed, that's right. And here you have that in the United States, the average of finger sticks in patients with type 1 is about 3. And if you look in there, you see that how they're given insulin, about 30% are now using pumps. So I don't think that 30% of type 1 diabetes in India right now are on pump, but the number I'm sure is increasing the same as ours. So, and finally, you heard yesterday about this technology, and you see that right now, a good number, like 20% are now using continuous glucose monitoring, and now we have several of them in the market and in the process of coming to the market. So insulin therapy is here in many ways, but there are many limitations that I mentioned before. Glycemic control is achieved by very few. The other thing is that whoever managed type 1 diabetes, you see that the swings are ups and down. They're all over the case. And they say, oh, doc, this morning was 40, and then in the evening it's 400. So how can we reduce glycemic variability? That's right. And taking the same dose every day, some days they're high, and some days they go hypoglycemic. It's very unpredictable. The other thing is weight gain. Right now in America, about 30% of patients with type 1 diabetes are obese. So because they eat same like you guys, and you have good control, and you eat too much, you gain weight. And there is no question that there will still be a lot of DKA. And data and observational studies have shown that patients with type 1 diabetes, similar to type 2 diabetes, really undergo coronary heart disease. So we need to have measures to improve diabetes care, that's right. So look at here. This is the average hemoglobin A1C in the type 1 diabetes exchange. I'm the principal investigator in Georgia for type 1 diabetes exchange. We have 25,000 patients together data with type 1 diabetes. And you see that in kids, this is hemoglobin A1C like this. When you're an adult, you're much better, but who, my goodness, I don't see pediatrics, but those who see adolescents, it's very hard. And the goal is to have hemoglobin A1C less than 7.5 for adolescents and kids, and less than 7 for the adults. So if you put a line here over 7, everybody is uncontrolled. And again, here you have how often they achieve hemoglobin A1C goals. So as I mentioned before, this is data for type 1 diabetes exchange, that's right. And here you have that if you say the goal is 7.5 for children, very few achieve goal, less than 7 of adults, about 30%. So there is no question that we need more than insulin to do this. So, and the current treatment is associated with very high risk of hypoglycemia, especially those who are poorly controlled. And you see it here for age. And overall, about 6.3% has one or more severe, not just little shaky, severe hypoglycemia that require mom, dad to help or call the ambulance to help you out or be admitted to the hospital. And this is what I mentioned before. This is the number of people who's now become overweight, obese. It's just unbelievable. It's just, and of course, when you get obese, you get this double diabetes, you get insulin resistant, and the management is difficult. And finally, look at this. This is the rate of diabetic ketoacidosis, which is supposed to be a preventable disease. It shouldn't happen. Nobody should get that's right. If you are diagnosed diabetes, you can prevent it. But unfortunately, you still see a lot of people, especially those who have hemoglobin A1C greater than 9, they are dancing on the line very close to becoming ketotic and be admitted with diabetic ketoacidosis. So with that background, I hope I convince you that we should need something else besides insulin therapy, something that helps reducing these complications. So there are several studies, every single drug have been tested. I'm not here sulfonylureas because that was tested 20 years ago, it didn't work. But you have amylin, you have metformin, DPP-4, GLP-1, SGLT2, and now SOTA, that is the combo SGLT1 and SGLT2. So I'm not going to talk about amylin because I know it's not available in this country. So sorry for that. But I'm going to start with metformin. So is metformin good for patients with type 1 diabetes? And there have been 2 studies. So the first study was done by Ingrid Lippman, she's at the University of Pittsburgh, and published in JAMA a couple years ago. And she gave kids and adolescents who were taking insulin about 0.8 units per kilo, so good insulin therapy, and followed them for 26. Half of them took metformin, half of them took placebo. And you see here in red is metformin, and in gray is placebo, and what you're looking is a change in hemoglobin A1C. So if you give metformin, 0.2% reduction of hemoglobin A1C. So if you have 8.1, 7.9. So, and here at the end of the study, no difference. So, if you look at the change in hemoglobin A1C, at the beginning there was a nice response, but then later on, at the 12 months, there was no difference at all. When they follow, this is the second study. This is, sorry, I deleted on some slide for this lecture. I only have 20 minutes. And this is the second study. So the first study was completely negative. That's right. I'm not getting too excited. Second study, this is in adults. And we just published in Lancet Endo 2 years ago. And when you see, if here you have in red is metformin, in placebo is gray, there was an initial response, but after 6 months, no difference. And here you have the insulin dose was reduced in both. And body weight, there was a significant difference, about 2 kilograms. So, can you give metformin to these patients? So, I'm playing. And here you have some other studies that have used metformin. And you will see is that, yes, you get somewhere around 0.2%, and a reduction of dose somewhere around 1 to 3 units. So because of this very mild effects of metformin with the increased incidence of GI side effects, the American Association of Diabetes Endocrinologists and the American Diabetes Association, we do not recommend added metformin in patients with type 1 diabetes. And here's the rate of side effects. That's right. So you see a lot of people with gastrointestinal side effects, number of events. This is 60. So too much for too little. What about pioglitazone? You guys use a lot of pio. Can I use pioglitazone in a patient with type 1 diabetes? That's a good question. And there's only one study that is really good, well conducted. And this is 50 in adult patients. I've never been done in kids. And these are people who were heavy, more than 27. So the investigators said, maybe this is a group that I can give an insulin sensitizer. That's right, makes sense. And they have 25 patients receive placebo, and 25 patients receive rosiglitazone on top of insulin therapy. They maximize insulin therapy and see what happens. And the hemoglobin A1C reduced at about 1.4%. So this is interesting. In this group with placebo, only 0.6% of these patients. But look at the difference if you have BMI greater than 30 or less than 30. So if you have a type 1 diabetes who is lean, you don't see much difference. This is the effects in the lean. But if you have one of those obese patients with type 1 diabetes, maybe pioglitazone help you improving hemoglobin A1C and also by decreasing the amount of insulin therapy. Unfortunately, as you know, thiazolidinedione has been several associated factors like osteopenia, question about bladder cancer. I don't believe this is the body weight, gaining weight. So most of my type 1 diabetes don't want to gain weight, so they don't take it. But this is an option for some of them. What about DPP-4? They're cardiovascular safe, they're weak, but they're effective. That's right, 20% of the people in this world take a DPP-4. So and this is studies, there is a crossover design studies with sitagliptin versus placebo in patients who have type 1 diabetes. And the question, the primary outcome was changes in hemoglobin A1C. So in red is sitagliptin. In gray is placebo. And this is a study that it was a short study, just 18 weeks. And there was absolutely no change, or significant change in hemoglobin A1C. So if I'm going to give this patient in America, sitagliptin is about $300 to $400 a month for 0.2%, the reduction in hemoglobin A1C, better just save your money. That's right, not good. What about GLP-1? Oh, everybody talks about this GLP-1 for the heart. Now it's good, it's injectable. One more injection, who cares? This patient already received too many injections. And if you look at here is different doses of liraglutide at 0.6, 1.2, and 1.8. Here are the colors versus placebo. Then you see a reduction of hemoglobin A1C, no question. Here is hemoglobin A1C. Here is total daily dose of insulin. There is a decrease. And here is body weight changes. So the use of liraglutide was effective in improving glycemic control, reducing weight and total dose of insulin. Unfortunately, if you look up here, you have a significant increase in the rate of hypoglycemia. So that's not good, that's right. And more importantly, here is the rate of diabetic ketoacidosis, especially with the higher dose of 1.8 milligrams. So because of, despite the improvement in glycemic control and little less insulin, they got more hypos, more GKA. So the American Association of Clinical Endocrinologists, the American Diabetes Association, that by the way, I'm a member of those committees, we decided to say, do not recommend GLP-1 for patients with type 1 diabetes. Well, what about SGLT2? That's come on. SGLT2 is good, it's cardiovascular protective, it's renal protective, blood pressure. Give it to patients with type 1 diabetes. And this has been a large area of research for all of these companies. They were approved for type 2, but they saw the business of type 1 diabetes. So, and the first one to report was the canagliflozin, Cana type 1. And what you have in here, Bob Henry reported that, improved hemoglobin A1C by 0.2, 0.4%. So 7.3, 6.9. but also reduce the body weight. If they lost about 3 to 4%, so about 2 kilos. Everybody got very interested in doing this. What about the others, dapagliflozin? Given to patients with type 1 diabetes, and they saw this reduction of hemoglobin A1C of 0.4%. And this is in kids, and this is the European, also a significant reduction of hemoglobin A1C. And this is the total daily dose of insulin. Great, because you bring the blood glucose down, and remember that these agents produce glycosuria, and that's the mechanism. It's independent of insulin. So as your blood sugar drops because you urinated, you excreted, your requirement of insulin reduces, that's right. And that's what they observed, not only reduction of hemoglobin A1C, but reduction of insulin therapy in these 2 trials. And of course, if you pee sugars, you pee calories, you produce weight loss. So in these studies, the use of type 1 diabetes, great, that's right. I mean, let's give it to everybody because it produced these things. But of course, what happened with all of these studies? In the Bob Hendry studies, 10% developed ketosis, 5% were admitted with DKA. These studies with the PIC 1 and 2, the number of urinary infections and the number of balanitis was significantly increased. So much more than we see with type 2 diabetes. And more importantly, I want to show you here events with DKA where it's about significantly higher comparing to those patients. So here, there were 11 patients, or 4% of patients with DKA versus none. And remember that DKA is the #1 cause of mortality in young people with type 1 diabetes. So there's already 1 case of death in type 1. So, and this is studies when people were trying to prevent diabetic ketoacidosis and people who were managed by endocrinologists. So maybe EMPA, come on, EMPA is great, EMPA-REC is good, save your heart. And there are a couple of studies done, and what you see in here is that EMPA reduced hemoglobin A1C, and there is a dose response. But what they did is very important, is that they did those days, in adult we use 10 and 25, that's right? But they did 2.5, just a tiny dose, a tiny dose. And you see that the reduction of hemoglobin A1C was not that great, it's about 0.3, 0.2, 0.3%. If you look at the total daily dose of insulin, not much with the 0.2, but there is some, about very little, less than 0.5, so almost nothing. But they all reduce insulin, but I want to call the attention to diabetic ketoacidosis, where the dose of 2.5 milligrams was very close to placebo. So maybe a half of the dose that we use may be appropriate for patients with type 1 diabetes. So the question is, doctor, can I use SGLT2s for patients with type 1 diabetes? Reduce hemoglobin A1C about 0.3%, 0.4%. It produced weight loss about 2 kilos or 1 kilo in these patients. There is not much increase in hypoglycemia because they reduced the dose of insulin. And confirmed DKA is still there. So finally, the American Diabetes Association did not recommend, but stay there. So the final is the combination of SGLT1 and SGLT2, that's right, sotagliflozin. I should say that I'm in the steering committee for 7 trials. I'm one of the principal investigators for several of these studies. And this is an agent that blocks the urine, SGLT2, and blocks carbohydrate absorption in the intestine. So, double thing. How they work in patients with type 1 diabetes. This paper was published by Satish Sarge in GARC in New England Journal of Medicine. 0.4% reduction in hemoglobin A1C at 24 weeks and about 0.2, 0.3%. So, a little bit. But I just want to call your attention to the last column that is DKA. And this is sotagliflozin. They still have 4 to 6% increased history of DKA. So the FDA in the United States told them, no way, you didn't pass. But the European Medical Association has approved sotagliflozin for patients with type 1 diabetes who had a BMI greater than 27. So how do I check? And this is my last slide. I'm sorry, I'm a little over my time. I'm a member of these committees, and I work with the FDA and work with, do I think that, should I use adjuvant therapy in patients with type 1 diabetes? I think we should maximize insulin therapy. We should maximize technology. Providing kids with CGM, providing kids with pumps may be more effective than to try to adjuvant therapy because of the risk of complications. Unfortunately, very few people achieve goals. Most oral agents in type 1 diabetes result in minor improvement of hemoglobin A1c, so 0.4, 0.3, 0.4%. There's no increase in hypo because you reduce the dose of insulin. Some of them may produce weight loss like GLP-1 and SGLT2. That's good. If you get somebody obese, maybe TCDs. Improve insulin resistance, but DKA is still the #1 cause of death in patients with type 1 diabetes, so we need to be very careful. And if you ever use one of these agents, always select the patients very well. Saying that, I can tell you that I have several doctors and a couple of nurses who are taking SGLT2s and they love it, but they have to be walking around with a kit to check their ketones because, as you know, many of the time diabetic ketoacidosis is euglycemic and they do not, it's hard to recognize who is in DKA. This is my last presentation, and I just want to say thank you very much for your friendship. And I really had a tremendous 3 days, and I just love India. Thank you.